Welcome to this presentation. We are going to continue looking at the paper by Walker and colleagues entitled Cardiac Mortality in Users of olmesartan, Other Angiotensin-Receptor Blockers and Angiotensin-Converting Enzyme Inhibitors. For any study, it is important to understand the data source, both its strengths and limitations. In this case, we have to understand the US healthcare system. A large US commercial healthcare insurance company provided insurance claims and enrollment data for this work. The insurance included drug benefits alongside with coverage for services. Although people of all ages were represented, the proportions of subjects aged 65 years and older was smaller than in the US overall. We also have to understand the study population, who was included in the study and who was not. Persons in this study were those aged 20 years age or older who received a first prescription of olmesartan, an other ARB or an ACE inhibitor. These were the study drugs between 2002 and 2009. For inclusion, an individual's first dispensing of a study drug had to come after a period of at least 183 days, during which the subject was eligible for insurance. The individual had to have no prior dispensing of any ARB. Individuals remained under observations until they terminated treatment with the initiating product, left insurance coverage, entered long-term care, died or reached the close of observation at the end of 2009. This slide notes further features of the study cohorts. Firstly, we noted healthcare utilization and drugs dispensed in 183 days prior to treatment initiation. Secondly, cohorts had close balance on demographics, diagnosis and drug classes dispensed, as well as on a variety of healthcare utilization measures. This slide tells us more about the comparison groups. Remember that the comparisons we make will have a big impact on the results. Within each of the 8 calendar years of cohort accrual from 2002 to 2009, and within strata defined by the prior use of ACE inhibitors or not, we formed cohorts of initiators of the study drugs with covariate balance achieved through matching initiators of other ARBs or ACE inhibitors to initiators of olmesartan using a propensity score particular to that calendar year and prior use stratum. In later slides, I will explore the terms that are underlined in this slide. One way of thinking about this study is by using the PICO framework. The PICO format is widely used in health research to help manage and break down the research questions. When forming your question using the PICO framework, it is useful to think about what type of question the study is addressing. The PICO acronym stands for P, which stands for patient, problem or population, I for the intervention, C for the comparison control or comparator, and O for the outcome. In this study, the population are people aged over 20 in receipt of the study drugs. There are no exclusion criteria. The intervention is olmesartan prescribed between 2002 and 2009. The comparator is another ARB or an ACE inhibitor prescribed between 2002 and 2009. And the outcomes are sudden cardiac death and death from any cause. Earlier we mentioned propensity score matching. What does this term mean? If we look at this slide, we can understand the difference. First of all, we can see that the study contains people who are in the treatment group and in the control group. Before propensity score matching was introduced, we might include all of these cases in the analysis, as shown here, and they would differ on things like age, gender, healthcare utilization, and so on. We would then try to use statistics to control for these effects. On the other hand, in propensity score matching, we do something different. We look at the cases and at the outset we select cases that are very similar in terms of these characteristics, and only these cases are included in the analysis. In this study, the propensity model retained 205 predictor variables. Matching on propensity score yielded cohorts with close balance on demographics, diagnosis and drug classes dispensed, as well as on a variety of healthcare utilisation measures. This slide explains confounding. We can see in the table that gender is not balanced between the two groups. We have Group A and Group A. Group A is ACE inhibitors and Group B is placebo. We can see that in Group A, 80 out of the 100 people are men. In Group B, it's only 10 out of 100. However, if we look at the outcomes in Group A and Group B, there's a difference. In Group A, 26% have high blood pressure. In Group B, 47% have high blood pressure. However, if we look at men and women separately, we can see that the outcome is the same for both groups. For men, 1 in 5 have high blood pressure, and in women 1 in 2 have high blood pressure. So the apparent treatment difference that we see would not appear if we adjusted for gender. In other words, if we created balance between the two groups on the basis of gender, we would recognise that the apparent treatment effect is caused by gender and not by ACE inhibitors. In most observational studies, there may be several variables that are imbalanced, and the propensity score methodology allows one to balance all the covariants and make more valid inferences about treatment effects. Another factor to consider is how is the study outcome measured. Definition of outcome might be important. This paper tells us that sudden cardiac death was classified according to an algorithm. It could be that other methods were available, but they are not considered in this paper. It is important to understand the analysis performed in a study. In this study, proportional hazards analysis was used. The study states that for each of the study endpoints, we undertook a proportional hazards analysis over strata defined by calendar year and prior use of ACE inhibitors. Note also the type of comparisons made, as this will be important in this study. In persons without prior use of ACE inhibitors, initiators of olmesartan were compared with initiators of other ARBs and with initiators of ACE inhibitors. In cohort members with prior use of ACE inhibitors, it was only possible to compare initiators of olmesartan and other ARBs. The previous slide mentions hazard analysis. The term used in the paper is common proportional hazards analysis. The usual method is a Cox's proportional hazards model, and this is described in this slide. A Cox model is a statistical technique for exploring the relationship between the survival of a patient and several exploratory variables. The Cox model assumes that the effects are constant over time. A Cox model provides an estimate of the treatment effect on survival after adjustment of other variables. In addition, it allows us to estimate the hazard of death for an individual given their prognostic factors. This slide shows how survival analysis works in simplified form. We will have a look at the different columns in this table. But just to mention column D, where it says numbered censored. A censored subject is one who has left the study prior to experiencing an event. So if we have a look at the first row, we can see that 10 people entered the study, and during the first period of time, 1 person died, and so we can calculate the proportion surviving until the end of the interval, which is 0.9. In the second row, we see the probability of surviving at 1.112 years, and that's given by multiplying the cumulative proportion surviving multiplied by the proportion surviving at this interval, and so on as we go down the table, and we can see the proportion surviving. These data can then be transferred into this figure here, and here we see a survival curve. So at the start, no people have died. And then as time goes on, we can see how survivorship changes during the study period. So what does a hazard ratio mean? The hazard ratio is the ratio of the hazard rates corresponding to two levels of an explanatory variable. For example, in a drug study, the treated population may die at twice the rate per unit time as the control population. The hazard ratio would be 2, indicating higher hazard of death from the treatment. The hazard ratio can be interpreted as the chance of an event occurring in the treatment arm divided by the chance of the event occurring in the control arm, or vice versa. A hazard ratio 2 could be misinterpreted by some as showing that patients in the treatment group progress twice as fast as those in the control group. The correct interpretation is that a hazard ratio 2 means that treatment will cause the patients to progress more quickly, and that a treated patient who has not yet progressed by a certain time has twice the chance of having progressed at the next point in time compared with someone in the control group. This difference between hazard-based and time-based measures has been described as distinction between the odds of winning a race and the margin of victory. Ideally, the hazard ratio should be considered alongside a measure of time to describe the size of the treatment effect. In many survival analyses, the best measure of time to consider is the median, the time at which 50% of participants will have experienced the event in question. So here we can see an example of the principles that I've just been explaining from a paper in the BMJ Open looking at hypnotics association with mortality. Here we can see different curves associated with either having hypnotics or not having hypnotics, and different age groups. And over here we see the hazard ratios which are derived from these curves. And we can see hazard ratios of 9.7 for people aged 18 to 55 and around 4 for the older age groups. So quite high hazard ratios which are derived from this type of analysis, which is taking the observation, the times of years of observation into account, as we saw earlier. Another concept which the paper discusses is power calculations. So the power calculation refers to how many people do we need to observe in order to find a particular effect. And the paper states that power calculations indicated that sizes for this olmesartan cohort above 25,000 with 2 comparators for each olmesartan initiator would have a greater than 90% power to detect risk ratios of 2 or greater for sudden cardiac death. In other words, there would be a 90% chance of finding significant results given the sample size and the effect size, which in this case is the risk ratio referred to here. And this slide just shows how we go about performing power calculations. And in this case, we're looking at calculating a sample size needed to test time to event data. These are not the data from the study. I've just put some hypothetical data in. So we've got power of 80%, type 1 error rate, in other words, the confidence interval of 5%, and we're looking at a hazard ratio of 2%, hazard ratio 2, with an overall probability of an event of 1%. So these are the kinds of parameters that we need to put into a power calculator, and in this case it returns a value of 6,500. Let's look at the results now, and we'll start off by looking at the baseline data. So from 2002 through to 2009, there were 42,000 olmesartan initiators who had not previously used ACE inhibitors, and 21,930 who had. The propensity models had 205 variables. These are not fully explained in the paper. At no point did they say what the 205 variables are. They just refer to general characteristics such as demographics, diagnostics, drug classes, and various healthcare utilization measures. The key point is that the groups are very, very similar. There was very little difference between the different drug groups in terms of these measures here. So we'll move on to what happens after the matching. The final matched cohort sizes for the comparison between olmesartan and other ARBs were 38,750 and 72,326 respectively for patients with no prior use of ACE inhibitors. So these cohorts are slightly smaller because some cases drop out due to the propensity matching that we've already discussed. And these cohorts had average observation times of 8.3 and 8.7 months respectively. So this is the first table from the paper, and what the authors are doing is providing background information to help the reader to navigate the results. And we have two parts to this table. We have all patients and matched patients, and we have the three different drug groups. You can see that the matched group, the sample sizes are slightly smaller. So 42,410 here, 38,750 here. And that's because of the propensity matching. We can see the distribution of variables in terms of, for example, physician stays. So there's some variability here, but after matching, there's very little variability. So we can see overall for the matched groups that there's very little variability on these variables which could affect the outcome. And here we see a similar table, but this is for the subgroup of people who use hypoglycemic agents. So you can see the sample sizes are much smaller than they were in the previous table. And we can also see that the matched cases are again pretty similar in terms of the variables that might affect the outcome. Now we're turning to the real results of the paper. This is really what we want to know. We want to know if there's a difference in mortality here between the different drug groups. And first of all, the table presents the mortality rate for the different groups, and then we see the ratio, which is the ratio between one drug and another. So we see the olmesartan group, the other ARB group, and this is for persons without prior use of ACE inhibitors. And this is for all initiators, irrespective of whether they had or hadn't used. And remember, if the ratio is above 1, then there would be a significant difference between olmesartan and the other groups. But we can see that in no case are we finding that. We can see that the death rates are fairly similar, the ratios are fairly similar, and in all cases, the 95% interval crosses 1. So remember that the 95% confidence interval is the interval that you're 95% sure that the true population value, as it might be estimated from a larger study. So what we're saying is that in the population, it could be that olmesartan users have a slightly higher death rate, or it could be that they have a slightly lower death rate. The actual ratio is 0.9, which is slightly under 1. There's certainly nothing to indicate a higher risk of mortality, and that's true of all the comparisons in this table. So now we're looking at all-cause mortality, and we see a similar pattern. Here's the mortality rate for olmesartan, here's the mortality rate for other ARBs and ACE inhibitors. In each case, it's slightly lower for the olmesartan, and there's nothing to indicate a higher mortality rate. This table looks at mortality rate from sudden cardiac death in prior users of hypoglycemic agents. Remember, these were the focus of the two randomized controls that we looked at earlier. And here we can see that the rate among olmesartan is higher. Not significant because it crosses 1. This is among people without prior use of ACE inhibitors, and this is among those with or without prior use. So this is an important point in the study, which is the correct comparison to make. The paper says, in the present study, the primary cohort without prior ACE inhibitors corresponds to the roadmap population. Roadmap excluded persons who had used ACE inhibitors or other ARBs in the 6 months before study entry. In the Orient study, by contrast, approximately 73% of the patients had used ACE inhibitors prior to study entry, and participants were required as part of the study protocol to continue treatment. What the paper says is that the combined results respond more nearly to the two external signals that prompted the study. So that's their interpretation of the data. Let's see how the authors interpret these findings. We'll look at the points that I've underlined. So first of all, the size of the source data and the opportunity for extensive confounder control mean that the results provide reassurance about the relative safety of olmesartan, as it has been used in the USA since market introduction in 2002. So almost all of these points are important. First of all, the size of the source data. It was a large study. Second of all, the propensity scoring allowed for control of other variables. And the point is about the relative safety. So we're not comparing olmesartan to placebo, but we're comparing it to other drugs. The second point states that the overall finding of lower cardiac mortality in olmesartan versus comparators effectively rules out an important mortality increasing effect of olmesartan. So some of the findings did have lower relative risks than the other drugs, although sometimes the confidence intervals crossed over 1, but they certainly weren't greater than 1. So we might accept this statement. Because it reflects actual use, the population studied here differed from the diabetic olmesartan users in the Roadmap and Orient studies. So those were randomized controlled trials. So what they're making the point that this is a study of actual use versus randomized controlled trials, and we have to make some decision about how we're going to evaluate those different studies. The next point of the discussion concerns the users of hypoglycemic agents, and here they state that these proved to be a small subgroup with large variations in estimates, and you'll remember that some of the relative risks were quite large, although not at the level of statistical significance. So their conclusion is that there is no overall indication of excess risk. However, they go on to say, nonetheless, for statistical reasons, the study provides only modest assurance about the relative safety of olmesartan in diabetic populations. So what they mean is here, for statistical reasons, because of the relatively small sample size and the large variation in the estimates of relative risk, we cannot really be sure. It's also worth noting the other limitations. There was a relatively short follow-up period. Remember, it was about 7 to 8 months, and no dose response analysis is reported. So the discussion goes on to note that the previous two RCTs were trials of olmesartan as a preventive therapy in a setting where placebo was an appropriate comparator, and any risk associated with treatment could be seen as an absolute risk of therapy. Non-treatment of people with hypertension, they argue, is not a therapeutic option, and so the question becomes, does olmesartan differ from other treatments, in particular other ARBs or ACE inhibitors, with respect to the relative risk of cardiac death. So this is a key point. Are people interested in the absolute risk of a drug compared to receiving no therapy? And is it the case that it's not a therapeutic option to have no treatment, when, as we saw earlier, there are alternatives, including exercise and diet? So that's why it's important to use your own critical judgment when evaluating a paper like this. So the discussion becomes more complex as it goes on. The paper goes on to state the study cannot answer the question of absolute risk in persons with hypertensions that might be approached in a hypothetical comparison with no treatment at all. As we've seen, they've said that this is a clinically irrelevant situation. What they then argue is that an observational study with active comparators, as this study was, rather than non-treatment as a reference group, runs a smaller risk of bias. This is because, by comparison with the expected medical differences between treated and untreated people, there is an anticipated rough similarity in characteristics between people receiving alternative therapy. I think they seem to be arguing that because all the people in this study were drawn from the same treatment pool, therefore they're all similar, whereas people who are not treated are different. But I'm not so sure that this makes sense, because if these people have a lower death risk, then why would you want to be treated? So these are arguments in the paper that need to be carefully evaluated. So a key point that the paper repeatedly returns to is the issue of confounding by indication, whereby it's not the drug that's causing the outcome, it's the fact that people getting a particular drug are more ill than the other group. So for example, if people getting olmesartan had more illnesses, then it could be the illnesses that are causing a higher death rate. However, in this study, we had a balance. They used propensity matching to make the cohorts very balanced, and they say that more than 90% of the olmesartan initiators were matched to initiators of other ARBs and ACE inhibitors with very similar patterns of diagnosis, drugs dispensed, healthcare utilization, and demographic characteristics. So that's why they repeat this point, that the results have validity. So although there may not have been confounding by indication because the groups are balanced in all these factors when they went into the study, there is another concern which the authors have, which was that the restriction of the initial analysis to people without prior use of inhibitors had the effect of focusing on a population of treatment initiators who may have been substantially healthier than those with prior ACE inhibitors. So they're worried that the population that they're looking at may have lower death rates because they're inherently healthier. So what they go on to say is, accordingly, the analysis most representative of the experience of olmesartan initiators generally may be the combined analysis that includes both persons who had and who had not used ACE inhibitors before cohort entry. So it is complex to try and evaluate all of these issues. Another issue which the authors draw attention to was the relatively short time span of this study. Average follow-up was 8 to 9 months from treatment, and they argue that this was adequate to evaluate the effects of the study drug over this time period, but too short to permit a dose response analysis, and they cannot rule out effects that occur over the longer follow-up. By comparison, the two other studies that were referred to had longer follow-ups. Let's just return to the abstract, which, as we said earlier, is the part that people might read and not read the whole paper. So as we saw, the results of this well-powered studies do not raise concern for the risk of sudden cardiac death or death from all cause among olmesartan users in comparison with other users of ARBs or ACE inhibitors, although, as we've seen, there are complex issues involved in this. From the main paper, nevertheless, from statistical reason, the study provides only modest assurance about the relative safety of olmesartan in diabetic populations, which, remember, was the initial starting point of the study. So that brings us almost to the end of our look at one pharmacoepidemiology study. As we've seen, pharmacoepidemiology is the study of the uses and effects of drugs in well-defined populations. Pharmacoepidemiology is the bridge between pharmacology and epidemiology. So pharmacology is part of the wider remit of pharmacovigilance, which involves the monitoring of the use of medicines in everyday practice to identify previously unrecognized adverse effects and assessing the risks and benefits of medicines. So with all this information, how would you interpret the data from this study if a diabetic patient asked you about olmesartan? Would you say that the study does not raise concerns about the drug? Or would you say that the study provides only modest assurance about the relative safety of olmesartan? Or would you conclude that it's not relative risk that is important, but absolute risk, and communicate the results of the earlier randomized controlled trials? As we can see, there are many issues involved in this. Shortly after the paper was published, the FDA published a report entitled FDA Review of Cardiovascular Risk for Diabetics Taking Hypertension Drug Olmesartan, Not Conclusive, Label Updates Required. The US Food and Drug Administration has completed its safety review and found no clear evidence of increased cardiovascular risks associated with the use of olmesartan in diabetic patients. As a result, our recommendations for use of olmesartan will remain the same, but we will require information about some of the studies to be included in the drug labels. Patients should discuss any questions they have with their healthcare professionals. So we can see that although the study that we just looked at did not show an increased risk, it may have had some impact on how information on olmesartan is presented.